afternoon, everyone, and welcome to the second in our second series of remote family law seminars. I'm Sian Smith, and I'm joined today by George Butler, who's a family law barrister who's been practicing family law for 16 years, specialist in public law proceedings, with a special interest in the psychology of family law. And Dr. Ben Lasky, who is a psychologist of more than 20 years experience and has been an expert witness for more than a decade, practicing in the southwest of England. In our last series, you may remember they talked to us about the psychology of care proceedings, emotional harm and the interim removal of children. And if you've not seen that talk, you can see it on our Chamber's YouTube channel. Tonight, they're going to be talking about complex PTSD and the family court, impact, intervention and implications. After the talk, which will be about 30 minutes long, we'll have some time for questions. If you do have questions for either Ben or George, please do feel free to use the Q&A function, which is down the bottom of your screen. If you pop your questions in there, then we'll try and deal with those at the end of the talk. Just as a reminder, this webinar is being recorded and you'll be able to access it via Chamber's YouTube channel after today. So now I'm going to hand over to George to get us started. Thank you.
Thank you very much, Sian, and thank you, Ben, for joining me again to look at the various aspects of the psychology of family law. I'm sure that practitioners will have noticed over the last few years that more and more often when we are having psychological or psychiatric assessments directed by the court, the expert is coming back with a different formulation for the way in which they are discussing the difficulties that our clients face. And that formulation comes under the heading of complex PTSD, CPTSD, or what's also referred to as complex trauma. And this is often seen as an alternative to, or in addition to, the more well-known psychological and or psychiatric disorders that impact our clients' parents within care proceedings. Now, this idea, complex PTSD, may well have the capacity to have a profound effect on the way in which the family court undertakes its work, because it affects the way in which we as practitioners in the court understands not just childhood experiences, but the parents' contribution to the harm that children experience, treatment and prognosis. It also affects the way in which practitioners work with parents, and it should inform what is becoming known as a trauma-focused practice. And so, Ben, I think I want to start by asking you, why is it that we have started to see quite recently complex trauma being mentioned alongside other more traditional diagnoses within the assessments that are being undertaken?
Well, I'd say that the idea of complex PTSD has been kind of gathering increasing traction amongst people who work in the field of trauma, probably over the last sort of 5 to 10 years, but specifically, it's been accepted as a diagnosis in the new ICD-11, which is the World Health Organization classification for disorders. And so that was published in 2018, which obviously then lends further legitimacy to that as a kind of label. It hasn't yet been accepted by the American Psychiatric Association, so it's not in DSM-5 or any revised versions of that as yet, but it is now formally recognised in ICD-11.
So in layman's terms, what is complex trauma?
So PTSD, post-traumatic stress disorder, is characterised by a kind of cluster of symptoms. So those very kind of broadly separate into 4 key areas. So one is kind of intrusive experiencing of the trauma experience, avoidance of things that are reminders, whether that's physical avoidance or kind of emotional avoidance. The negative changes to thinking and mood, so that might be increases in anxiety, hopelessness, depression, and also hypervigilance for threat. And PTSD can arise from a single trauma. The difference with complex PTSD is it's generally it's accepted as arising from chronic exposure to repetitive trauma. And perhaps the three key things that are particularly interesting in the context of the family court are that it also includes problems with emotional regulation, difficulties with self-concept, and interpersonal difficulties, which I think it's fair to say we see in a lot of the people who are subject to the family court, certainly in the field of care proceedings, which is my main area of work with the family court.
So how is it then that this, either this diagnosis or this formulation, depending on how it appears in the literature, how is it that this diagnosis differs from, or indeed is similar to, all of the other sorts of diagnostic criteria we're much more used to dealing with? So, for example, personality disorders, autistic spectrum disorders, anxiety, Asperger's, ADD. What's the overlap?
I suppose in a way, it's almost a question that you would have to ask on an individual basis, case by case. But what I would say is that you could almost look at, I mean, in terms of the prevalence within the public law arena of the family courts, in my experience, I'd say that you're looking at a kind of prevalence of complex PTSD of around 90 to 95% of the parents coming through that system. Now, that's an absolutely huge, what's the word? I can't quite think of the right word. That's a huge prevalence. It's very, very, there's almost no other kind of situation where you'd see that kind of level of a specific disorder arising. I suppose what I would say in terms of the overlap or distinction between other diagnoses that might have been used more historically or might still be used is that there are quite a number of these diagnoses that trauma could explain a presentation, for example, that's consistent with ADHD, in that someone who's lived with a background of high levels of threat in their environment is likely to struggle to focus their attention, to tend to be scanning. So rather than focus on what's in front of them, tend to be scanning in the periphery for threat, tend to respond very quickly to a perception of elevated threat. So that could appear as distractibility and impulsivity as per ADHD. Similarly, someone who's experienced high levels of trauma, particularly during developmental phases where they might have otherwise been learning social skills, may present as though they struggle with empathy or struggle with certain sort of social and relational elements. As I've already said, interpersonal problems are one of the diagnostic features of complex PTSD. So on that basis, you might see people diagnosed, or the question as to has someone got an autistic spectrum difficulty, which may actually be trauma linked. The reality is, if you look at people referred into mental health services, generally speaking, you see a high level of comorbidity, certainly in child and adolescent mental health services. I think the studies tend to find that you're looking at approximately a level of comorbidity of 4.1 to 4.7. So a child coming in the door would on average qualify for around 4 different and distinct disorders, which may speak more to the fact that some of those disorder labels are slightly problematic.
I think that probably then presents a difficulty for us as practitioners, because of course what we might ask you if you're in the witness box is, first of all, how are we supposed to differentiate, say, between somebody who's got an emotionally unstable personality disorder and also has that described as complex trauma? And then secondly, does it really matter whether we differentiate them between them in any event? Does it matter if we differentiate? What's the purpose of this new diagnosis?
Well, I can't really speak to what the purpose of it is. I suppose what I hope is it helps us to take a view that's perhaps more compassionate, in that we're just, although, for example, an emotionally unstable personality disorder label or a complex PTSD label might both be used to describe the same person, the same pattern of difficulties, inherent in the complex post-traumatic stress disorder label is the central acknowledgement that the person's presentation arises from having had the exposure to multiple damaging experiences. And my hope for that kind of going forwards is it leads us to be able to be more understanding, compassionate, and hopefully to think about how we intervene to support people, rather than giving people a sense that for some unknown reason they have a problem with their personality, which I think is the message that sometimes people can take from personality disorder labels.
But if what you're saying is that, look, essentially somebody who comes in for an assessment, a psychological or psychiatric assessment, might well have any number of the psychiatric or the psychological disorders, and overlaid on top of that, it's likely that they've all experienced trauma as well. What implication does this have when you're making recommendations for treatment?
I suppose, George, that I think there are potentially quite a number of different implications. One, perhaps, is that when we're thinking about identifying the appropriate treatment for somebody who needs some support to move forwards, it may be that we are helped less by what's the specific diagnosis than by saying what are the issues here that are really having this person be stuck and having them find it difficult to address a particular area of problematic functioning in their life, and what's the best way to address that specific issue, rather than saying this is the disorder, these are the guidelines for this disorder, we'll give this person 15 sessions of CBT and they'll be fine. Does that answer your question or not quite?
It does, but what concerns me as a practitioner is that if we have a client who's got schizophrenia, we know that there's a treatment program, take the antipsychotics, etc., engage with the community mental health team. Even with a client with borderline personality disorder, we know that the recommendation would be 6 to 12 months of dialectic behavioral therapy, etc. If there's another diagnosis on top of the one that they've already got, is this going to affect their ability to access treatment? Is there indeed a treatment profile that's recognized for treating emotionally unstable, for treating complex PTSD?
Yeah, well, that's one of the areas where, at the moment, I feel that we're in an in-between phase. So evidently, when you have a diagnosis that's only 2 years old, there's a restricted opportunity for that diagnosis to have been fully researched. So whereas we've got the personality disorder diagnoses as a kind of category are more like 20 or 30 years old, and then depression, anxiety, things like that we've got very well validated treatments for much older again. So at the moment there are recommendations, and those vary slightly from country to country in terms of treatment for complex PTSD, but there is a lack at the moment of good quality outcome data. And generally speaking, what the recommendations at the moment are extensions of the treatment recommendations for post-traumatic stress disorder. If you look at the kind of writers at the forefront of trauma work at the moment, there's a fairly broad acceptance, which hasn't yet perhaps made it into the mainstream literature, that the treatments indicated for simple post-traumatic stress disorder, so that is traumatic stress arising from a single traumatic event, are not likely to be adequate for treating complex PTSD. And there's a kind of I came across a nice quote by a chap called Julian Ford, who suggests that in complex post-traumatic stress disorder, especially that arising from early trauma, so developmentally incurred trauma, he says diagnosis, treatment planning, and outcome are always relational. So I think what he's saying there is there's a need for people who've had an experience of disruption or betrayal in their own caregiver relationships at an early age to have a reparative relationship experience within a therapeutic work, to allow them to recalibrate, if you like.
in lay persons, or perhaps in lawyers' terms, I might reclassify that as 6 to 12 months of therapy with an experienced therapist, where the relationship between patient and therapist is the key.
Yeah, I think there's a. I think what you're saying, that those last few words are the important bit. So for example, cognitive behavior therapy doesn't explicitly work with the relationship between the therapist and the client. And I think what you'd be saying is, okay, if you're looking at someone who's got a complex trauma history, they're going to need some therapeutic work in which the relationship and the trust issues that are likely to arise in that are explicitly the focus of the work, included in the work.
But isn't one of the problems with this new diagnosis from a...
Hang on. Don't come in. Sorry, everybody, that's one of my children.
The dangers of Zoom calls. Isn't one of the problems, though, with this diagnosis from a family court perspective, or indeed from your perspective as somebody who does assessments, that whilst on the one hand, it's supposed to present a more compassionate way of understanding people's difficulties, to put it another way, it's not your fault that you've suffered this trauma, but actually we're not in a position to offer a properly assessed set of remedies that are going to work within the time frame that we're used to working with in the family courts. You're not going to fix this problem in six months, or indeed much longer, are you?
Well, I think that I think what I'm kind of expecting is that as complex PTSD takes more of a hold, we're going to see a lesser usage of the personality disorder labels. And my suspicion will be that eventually what we end up looking towards in terms of treatment for complex PTSD will overlap quite strongly with the personality disorder treatment. So I think dialectical behavior therapy, for example, offers a strong kind of strong potential for working with these with people who have complex PTSD. But you're right, at the moment we are in a difficult zone in that we have a lack of balance. So while we're looking at something that offers a kinder perspective, it has the potential to say, okay, we don't really know what's going to work with these people. In fact, people with complex PTSD have been receiving treatment through services for years and years. It just hasn't been called that. So.
No, that's I think where I'm coming from. Just as a slightly different angle, when you do assessments and you look at the way in which parents' behaviour affects children, can you give a sort of a bite-sized summary of the way in which you might expect a child who's being brought up by a parent with complex trauma to experience that parent? What are likely to be the headlines?
Well, I suppose that in a way you're going to expect, I mean, complex PTSD can present in quite different ways, but if we're looking back at those kind of core things that distinguish complex PTSD from simple PTSD, we're looking at the issues of struggling with emotional regulation, problems with poor self-concept, and difficulties in interpersonal relating. So what we're likely to see is parents who struggle to maintain stable adult relationships and may struggle to respond in a kind of predictable way to a certain extent. So that may be that you have parents who are predictably available and periodically overwhelmed, and then additionally less able to kind of attune and be present for their kids. Or it may be parents, so that the one way it might go is that parents become periodically kind of flattened in affect, less available, if that makes sense. And another way it may go is that you may have parents who respond more kind of explosively, if you like. So they may be sometimes alarming. So, but in either case, you'd expect that to have some impact on children's attachments as they form. Given that you've indicated that one of the key indicators is this idea of a self-image, self-concept, and there's also, I think you've indicated, a difficulty with parents assessing threat or
with a reappraisal. Is there a reality that a parent with complex trauma may actually see their child as not just a trigger, but also a threat?
Well, I would say that it can certainly in my experience, and it's certainly not universal. I think some parents are very good at separating their own trauma triggers from their child's behaviour. But I've certainly come across some parents who've experienced normal expressions of developmentally appropriate autonomy as a kind of challenge or a threat. So it certainly is a possibility, although by no means a certainty. But and then again, it may be that perhaps depending on the age that parents were traumatized, if you have a parent who was traumatized in their early teens, it may be there's a particular period of sensitivity around their child's development when their child reaches the same developmental stage. And we do sometimes see this in families where, for example, a parent who's been thrown out of home in quite traumatic circumstances, at the age of 13 or 14 or 15, you may find that history repeats itself with their own children or with one of their children.
You said a little earlier on that one of the indications for treatment is that treatment needs to be relational. And I know that at the moment, certainly trauma is treated with anything from EMDR through trauma-focused CBT, trauma-focused yoga, mindfulness, etc. But given that there is this relational aspect, what implication does that have for practitioners? So for a lawyer or a social worker, someone who's actually in the room with a client who experiences the world through this lens of complex trauma?
So I suppose what I would, if I was kind of going to give people a little bit of advice, what I'd say is if you're looking at someone who's had the experience of repeated exposure to trauma, and if particularly that has arisen in an interpersonal context where people who one would if everything were working properly expect to be keeping the person safe, treating them respectfully, working in partnership with them. If their experience has been other than that, so experience of betrayal or of abuse from people who one should be able to expect the opposite, what you're likely to find is that interpersonal situations as a starting, particularly with authority figures, will be viewed as potentially threatening. So that's almost before you've stepped into a room with someone, it's helpful to be aware that they may experience you as threatening, even if you're not doing anything that's objectively threatening. Does that make sense?
It does, and I'm wondering.
And so it's almost as though the experience of trauma turns up the volume on someone's idea of perception of threat. So these, rather than most of us walking around perhaps with that volume being at a 2 or a 3 or a 4 or a 5 in certain settings, someone who's experienced multiple and repeated traumas may be moving around the world with their threat indicator turned up to an 8 or a 9 as a starting point. So one of the things that I often do in my sessions is at the very beginning, I'll say to people, look, I try to be kind to people, I try to be respectful, I'm not going to be saying anything mean to you, but if at some point during this session you think I'm being rude or saying something that's unkind, or I've taken something you said the wrong way, please let me know. If you don't feel you're able to and you want to get up and walk out of the room, or you think I'm being a dick, then please, the door's just there, please walk out of the room. But if you could try to not go very far, I'll come and try to find you in 10 minutes once we both have a chance to calm down. We'll see if we can work out a way to start again. And it feels to me that saying that to people, often it's quite good because it breaks the ice, because I think it makes people realize you know they may find you difficult. In the event, I've only had someone storm out of my sessions possibly 2 or 3 times in the 12 years I've been doing this work. And in the most recent one of those, I was the chap involved didn't want to come back in. He was too distressed, but we were able to we had a kind of 10-minute walk around outside, and he then came back and finished the assessment another time. So I think there's something about setting up an expectation. If it goes wrong, I'm going to be the one to try to fix that it may well go wrong, and that if we can set up some expectation of how that would work with the person we're talking to at the beginning, it just makes it more manageable. Does that?
It does. I think I know one of the issues that we have with clients a lot is you have, for example, a social worker telling a client that they've got anger management issues, and then in the next breath saying, "Don't get angry with me," which seems an unrealistic expectation. And I seem to tell my clients it's perfectly fine for them to get angry with me. I figure that's part of my role. But none of us practitioners have specialist training in dealing with this large group, probably the majority of our client base. And I don't know of any specialist training that is specifically available for lawyers. From your perspective as a psychologist, do you think that specialist training of one form or another would be important, essential, given how prevalent the diagnosis is?
I think it would be helpful to have a broad understanding. I mean, I think the reality is, people train for years and years to do trauma work. I work mostly with people who are traumatized, but I wouldn't consider myself a trauma specialist, certainly not from a therapeutic point of view. And I think there's something about knowing enough to make sure that you're working kindly and respectfully with people. And in a way, what we probably mostly need to avoid doing as far as possible is responding to people's expressions of their trauma in a way that further traumatizes them, if that makes sense, by blaming or shaming or rejecting.
That brings me, I think, probably on to my last set of questions, which has to do with, I think, what we're calling either the trauma-focused court or something similar to that. What's your view on this idea of a trauma-focused court practice?
I mean, I think it's a great idea. I think it's certainly a helpful discussion to be opening up. And my understanding is it's a reasonably new discussion. I did have a little look around online. I think one of the things about it is it's quite a difficult thing to manage. So one of the things that I read, which was from the States, said if we're setting up a trauma-informed court, what we need to avoid are giving people the experience of loss of control, judgment, or any sense that they're under threat. And I think of the parents who are coming through the door where the threat that they're looking at is the catastrophic disintegration of their family, which is outside their control and based on a judgment that they are not equipped to look after their children safely. And then I wonder how we could provide a court without fundamental redesign from the ground up that avoids triggering parents in those ways, where those specific triggers seem to be at the heart of what the family court does.
Well, I was going to say, I might put it more bluntly as a practitioner, and over the years of cross-examining parents or representing parents, I'm not saying I do, but there are certainly some practitioners who almost seem to take a glee in setting off triggers, and that's clearly, first of all, not going to get you very good evidence, I would have thought, but it seems to be doing exactly what you've just identified, which is a trigger is essentially a re-traumatization in the court context, isn't it?
Well, I think that's certainly the risk, and I think that for a lot of parents, one of the things I think is quite difficult sometimes for practitioners to remember, and I go to court probably 4 or 5 times a year, or some years slightly more, some years slightly less. That it's quite important to remember that the context of court in itself is quite intimidating and difficult for most people, even if you're not to talk about your own children or matters that are distinctly personal to you. And I think one of the things that we really do need to remember when we're working with if you want clients of the court, parents coming through the court system, is that actually just that system in itself for most people is intimidating and difficult. And I think it's quite difficult to remember that when you're in and out, on a weekly basis.
I think finally, this might be a bit sort of crystal ball gazing. I take it from your answers that the current way that we undertake court proceedings really does not take sufficient account of our clients' abilities to give evidence well, to participate well, not to be re-traumatized themselves. And I'm aware that sometimes the Family Drug and Alcohol Court has been at least tried in some local courts to address non-FDAC sort of issues, where the issues are far more emotional and trauma focused. Do you think that that model of far more regular interventions, therapeutic and other supports, as opposed to the more, well, I suppose it's confrontational model that we have now, is the way in which the family court should be heading for all of these sorts of hearings?
Yes. I suppose I'm being a bit flippant. I suppose it depends on how far you want to go. Really, I think the reality is that there are, the majority of our parents are probably not best served by an adversarial system of cross-examination. Having said that, I think the family courts get a lot of things right in difficult situations, and I think it's a question of, I come from a background professionally of very early intervention, so I spent 5 years in Salford doing running parenting groups with the under fives or under eights. Anyway, largely it was under fives, and many of those families would be the families that, without the access to early intervention, would eventually have been at risk of ending up within the family court arena. So, but that's very, very early intervention. Unfortunately, over the last 10, 12 years or so, we've lost a lot of those early intervention services. So what's happening is that families are coming into social care system at a much later stage of difficulty, and very often social work teams have a limited range of options that they can actually meaningfully offer. And there's the phrase, if all you have is a hammer, everything starts to look like a nail. There's a difficulty if you have little to offer families other than removing children, that more children are not being removed than might be if you had a range of early intervention services in place. So the court, I think I take your point that if the court were able to use more of an FDAC model of being alongside parents and supporting them and working at intervention and getting things changed, I can't see any argument that wouldn't be an improvement. Obviously, the question, as is always the case that we come up against, is one of resource. And then one of the things that I often find quite frustrating is that the costs of removing children from families are immense. I remember looking at it around 10 years ago, and I think the average cost was something like £55,000 for a child removed into local authority foster care in the first year. And that's obviously costs, including court process, things like that, all pulled together. Now, for £55,000 or a fraction of that, you could put an enormous amount of therapy and intervention into a family. So I think there is the kind of lack of pooled budgets means that perhaps we don't have perhaps we don't use that resource in the most intelligent way.
Right, well, as I said, I think at the end of the last seminar we did, I could probably talk to you about this all afternoon, but I'm sure that the other people joining the seminar have got other things to do. I'm not necessarily going to say better. Thank you very much for taking the time to join me, Ben. And I think if we wait there, Sean may have some questions from the participants. Thank you, Sean.
Yes, thank you very much, George and Ben. That was really, really interesting. I'm going to start, I think, with a question from the audience. Two-part question for Ben, please. Is it possible for people to recover from complex or simple PTSD through self-help alone, or can it only be done with assistance?
So, I mean, what I would say is that there's more than one way to recover from things. So if sometimes reports in the family courts would seem to suggest that unless someone gets X, Y, or Z therapy, there's no prospect of them making progress. And in fact, certainly in my experience, when I've seen people for a follow-up assessment, that either whether it's someone I've seen previously or somebody else has previously assessed, I've often seen people make a huge change without necessarily accessing therapy. What I would say is that if you've got access to a good quality, experienced and skilled therapist who you work well with, it's likely that recovery will be much quicker than it might be through other ways. But there's also increasingly a kind of movement around more physical approaches to trauma. So some work of people like Peter, Janina Fisher, Bessel, van der Kolk, talk more about psychic and physical approaches. And George, you mentioned earlier on trauma-focused yoga, which is something that I've come across in name only. It's not something I know very much about, but so there are ways in which people can access different channels to improve things, and certainly some of that may be done with self-help. In some ways, it perhaps depends on how much resource and background support that person has. So if they're living in a chaotic environment, it's going to take longer if you're trying to make those changes on your own steam than it would do if you were, for example, well supported in a reasonably stable and safe environment. Does that answer the question, Sian?
I think it does, yes, thank you. And I'll give you the second part of it now. It's another interesting point on treatment, which is about whether the treatment is usually, or perhaps even I would say sometimes, offered to the family for family therapy, or is it usually focused on the person having suffered the trauma?
It would ordinarily be focused on the person who has suffered the trauma, but there certainly are again, it depends a little bit on the context. So I think if you're presenting within the family courts, it would be quite common if someone were assessing a parent to say, look, this is the work that the parent might need themselves individually to deal with a complex trauma. In terms of their parenting, they may need this practical support. They might also benefit from a parenting group. Perhaps it would be good to look at some attachment promoting interventions. So in terms of a kind of comprehensive assessment where someone's free to suggest, if you like, different channels through which support might be accessed, in a way it's both and. But if you were looking at someone, so it was a family member of mine seeking support themselves for complex trauma, they would be likely to go to their GP, be referred to mental health services and treated as an individual rather than in a more global way.
Ben, I've got another question for you. Given that complex trauma is both a formulation but also a diagnosis, from your perspective as a practitioner, is it more useful to see it as a way of understanding a parent's experiences, or is it more useful as a diagnostic criteria?
I suppose it's potentially, I mean, in a way, diagnostic criteria in mental health, there are some difficulties with them. I was reading a thing by Mary Boyle who says diagnostic labels lack specificity, causation, and validity, which makes them sound pretty poor. In a way, if a diagnostic label provides a good and accurate description of behaviour and some pointers as to treatment, then it's helpful. But it's not like, you know, if you're looking at someone, do they have a broken leg? Well, the bone is fractured. Yes, this is a broken leg. There isn't a comparable structure in the brain that you can look at and say this is complex trauma. What I would hope in terms of the context of the family court is that the advent of the new diagnosis gives us a more kind, balanced and measured approach to understanding somebody's experience at this stage. I hope the diagnosis will become increasingly useful as there's further kind of research on validated treatments.
Sian, I can see there's another question here, which rather bizarrely is for me rather than for Ben. And it says, what advice would you give to aspiring family law barristers? And I think in the context of this discussion, there is something that I'd say, which is that you need to get out there and really experience what it's like working with parents who have all sorts of difficulties. You need to know what it's like to be in the room, as I once heard a therapist put it. You've got to be able to be in the room and tolerate somebody else's distress without it affecting you. And if at all possible, being able to hold some compassion for them. I think one of the hardest things as a practitioner that we have is being thrown in at the start of your career and having to handle enormous amounts of emotional distress coming from parents whose children are removed, who might be adopted, who might not be able to tolerate the room that they're in, etc. So I think my advice, just from this perspective, would be get as much experience as you can, volunteering or whatever it is, but get into a room in a supportive capacity with people who are in distress, and just make sure that you can tolerate that. Because I know that it's taken me years to develop that particular muscle. It doesn't come easily. Ben, is that your experience of working with parents in distress?
Sorry, George. I zoned out slightly because you were because you were talking. Yes, broadly speaking, I'd agree that getting experience of the real life situation is helpful, and I think there is something very valuable in figuring out as early on as you can what type of work is work which feeds you. It doesn't cost you an unconscionable price. Certainly, we were very lucky in our training that we got to work with different client groups, and I know that that's, for me, this work is work that I really enjoy and find stimulating, and I feel I'm making a difference. I've got a lot of colleagues I trained with who wouldn't touch it with a barge pole because it's not there and it doesn't fit well for them. So I do think there's something about figuring out as early as you can, is this the area for me?
Thank you very much. Well, Sean, I think that probably takes us up to our time limit. Ben, I want to thank you for, again, joining me to look at this area of complex trauma. I know that there's a lot of work that needs to be done within the family law process and within the courts in particular to really start to take on board what you've been talking about. And we're probably in the foothills as opposed to much further on in that. But I hope that everyone at least can take away something in terms of how they deal with clients who clearly have had much more adverse life experiences. Sean, I think over to you with a summary of what's coming next, isn't it?
Yes, thank you very much, George, and Ben, for a really thought-provoking talk. I'm sure we could have gone on asking questions all evening, but unfortunately we do have to draw things to a close. But I would like to, before we go, invite you to join us for our next seminar. It's on the 1st of December at 5 o'clock, where you'll be able to hear Desmond Kilcoyne and Jeremy Hall giving a case update on Talata, so everything you need to know to bring you up to date on recent Talata case law. So thank you all very much for attending this evening. We hope you've enjoyed it. Please look out for our upcoming seminars in the rest of the series, and we hope to see you again. Good night.
Thank you.